Hello, all. Let us learn about MRSA infections, current status, and the future scenario. If it's, let's see this is a chart. This shows the timeline of the antibiotic introduction and resistance. If you can notice here, within years of the development or discovery of the antibiotics, within 2 to 3 years, the resistance has been reported. So if you see penicillin developed in 1940, within years it developed resistance against similar for tetracycline and methicillin, vancomycin, imipenem, and others. In recent years, the development resistance has been still faster. Within a year of development or discovery of the antibiotics, the resistance developed against particular antibiotic. What is added by the CDC report on antimicrobial resistance? Nearly 1,20,000 staph bursting infections and 20,000 associated deaths occurred in the US in 2017. After years of progress, the rate of decline of MRSA bursting infection has slowed, whereas bursting infection caused by medicines susceptible staph are increasing slightly in the community. What are the implications for the public health practice? Adherence to CDC recommendations such as for preventive device and procedure-associated infections and interrupting the transmission along with the innovative tailored interventions are needed to prevent further these infections. You can refer to the articles Epidemic and Recent in MRSA and the medicines susceptible staph bursting infections in the weekly article. But what is this medicine resistant staph aureus? It is a gram-positive cocci that is resistant to beta-lactam group of antibiotics, which includes penicillin, cephalosporins, and carbapenems, and monobatum such as H2num. MRSA causes a variety of disseminated lethal infections. This bacteria colonizes skin in approximately 40% of healthy people. Frequently, staph aureus is cultured from the nasal passages in approximately 30% of the healthy population. The evolution of the increasing microbial resistance is multifactorial, but the overuse of antibiotics is one of the causes, which puts up a selection pressure on many pathogens, including staph. But the mechanism of resistance includes development of the alteration of the penicillin binding proteins, which occurs because of development of a alter mutation in the gene and development of a MACA genes. That is from the MAC to MACA gene. This gene is responsible for development for alteration of the penicillin binding proteins, which inhibits the entry of the beta-lactam antibiotics and hence this action. Now this MECA gene as well as the MEXI gene are responsible for the MRSA. MEXI gene is a homologue of MECA. It was initially designated as MEC-AL-251. It shares near the 70% homology with MECA. The MECA gene and penicillin binding protein 2A lattice aggregation fails to detect the MEXI gene. In sensitive testing using both cefoxitin and oxacillin, MECA-MRSA shows resistance to both antibiotics, whereas the majority of MEXI-MRSA will express resistance only to cefoxitin. Hence, the correct testing will be to do by oxacillin testing. The discrepancy is explained by the observation that penicillin 2A produced by MEXI strains have higher affinity to oxacillin than cefoxitin. That was a change in the structure of the penicillin binding protein. The penicillin binding protein converts to penicillin binding 2A in staph aureus by the acquisition of this MECA gene, which decreases the ability of the beta-lactam antibodies to bind and produces the axons. Now, the glycopeptides such as vancomycin also work by inhibiting the cellular synthesis and by depolarizing the cell membrane. Now, resistance to vancomycin has also been a major issue, especially in enterococci infections. And this resistance in enterococci develops because of other sets of genes such as 1A, B, C, E, 1A, B, D, and G phenotypes. 1C affords intrinsic or natural resistance and is chromosomal nature, while 1D, E, G is represented only sporadically. 1C and 1E causes an alteration in the D-deoxyribonucleic chain of the amino acids of the cell wall of the gram-positive bacteria. While 1A and 1D causes resistance to vancomycin and teicoplanin, 1A and 1B causes are the most common. The phenotype is accompanied by multiple proteins in the gene cluster. So the transfer of the genes, this 1A, B, and DA, and other such genes takes place by three major mechanisms like conjugation, transduction, and transformation. Is a type of staph bacteria that is resistant to beta-lactam group of antibodies, as I said before, and it causes a variety of life-threatening infections like bloodstream infections, surgical site infection, and pneumonia. The risk factors include recent hospitalization, prolonged stay, prolonged antibiotic therapy, and invasive devices. There are three forms of MRSA. One is community acquired, one is healthcare associated, and one is livestock associated MRSA. Healthcare associated include the factors associated with healthcare associated include after more than 2 days of hospital stay, and is often resistant to multiple antibiotics, and it's responsible for a great percentage of invasive devices. Infection caused by healthcare associated MRSA includes bloodstream infection, urinary tract infection, respiratory tract infection, surgical wounds, and device associated infections. For acquiring hospital acquired MRSA include previous admissions, impaired immune systems, use of multiple antibiotics, use of invasive medical devices, and old age. Hospital acquired MRSA carries SCC, typical chromosome cassette types 1, 2, and 3, and usually multi-resistant to antibodies and tend to multiply slowly in culture. History of recent hospitalization. Typically, the community acquired MRSA causes skin and soft tissue infection, and there is no history of recent hospitalization. It is responsible for 14% nationwide MRSA infections occurs mostly in athletes and military deployments. It's harder to tell whether there is a community acquired or hospital acquired MRSA infections. Mostly there are the community acquired causes skin infection like impetigo, cellulitis, psoriasis, and boil. Also causes necrosis, fasciitis, septic thrombophlebitis, arthritis, and bacteremia. They are usually susceptible to non-beta lactam antibiotics and they carry smaller sized as SCC, that is chromosome cassette. They multiply faster than the hospital acquired MRSA strains. The difference, there is a healthcare context in hospital acquired, but there is nothing such similar in community acquired. However, the antibiotic resistance is to many antibiotics in hospital acquired, where it is few in some community acquired. The mean age is older in hospital acquired, while it is younger in community acquired. Invasive MRSA infections are healthcare associated infections. This is a important cause of infection in livestock too, causing economic losses. MRSA also causes invasive infection in human being causes such as endocarditis, osteomyelitis, and ventricular acidic pneumonia. There is a global distribution of the epidemic MRSA clones, as you can refer from this article on current medicine research and practice. So what are virulence determinants of Staphylococcus aureus? This includes protein A, capsule, cell wall, then enzymes like hyaluronidase, staphylococcus, leukocytin, leukotoxin, then fibrinogen 15, and damaged tissue. They cause the release of the toxin and toxic shock syndrome toxins and exfoliating toxins and cell causes which causes in further cell membrane damage, toxic shock, exfoliation, and emesis. One of the toxin, daily toxin produced by Staphylococcus is panther toxin, called as is a combination of proteins which destroy the leukocyte by creating lactic pores and associated with necrotic infection of skin and subcutaneous tissues. Similarly, proteins called arginine catabolic mobile element is another such a toxic factor produced by Staphylococcus aureus. MRSA is spreading worldwide and it is resistant to worldwide. The prevalence, as you can see from this picture, is most common. The red ones are the 25 to 50% of the prevalence, and most common in the Southeast Asia and parts of America. So occurrence in India is increasing. Nearly 30% of the gram-positive cocci are Staphylococcus aureus, and 30% of them are MRSA. Antibiotic resistance to Staphylococcus aureus is increasing through years as compared to the resistance against other antibiotics. The overall prevalence of MRSA observed in one of the study of published in India of Medical Research was about 41%. Isolation rates for MRSA from OP or outpatient or ward and ICU were 28, 40, and 43% respectively in 2008, which increased significantly in 2009. What are the current perspectives? The staph aureus have been reported to increase exponentially from 29% to 47% in the 5-year period from 2009 to 2014. Apart from MRSA, VRE strains are also increasing from 1 to 92%. There has been a number of studies I can see from the slide where across India, the number of the prevalence of MRSA as well as VRE is increasing. It is a specimen distribution. It is more common in the pus samples and followed by respiratory, and blood samples. It is necessary to monitor this antibiotic susceptibility of the staph aureus and to prevent and control the It has been associated that the lineage resistant staph aureus, the medicine resistant staph aureus, medicine sensitive staph aureus, TGC sensitive staph aureus, and vancomycin resistant staph have been studied, and a decline in the drug activity against staph aureus infection represents a looming threat. Surveillance is required that the isolation of the patients when MRSA is found, they need to be isolated, screened, transmission-based precautionary should be followed. There are various testing methodologies that are available for MRSA, such as positive testing, lattice aggregate test for penicillin 2A, and antolimitic chain reactions. Each have their own advantage and turnaround time. However, the most conventional cultures are not recommended. There are better methods such as gene expert, which provides a quicker turnaround time, and for the immediate control and prevention. There are also chroma aggregated color based media culture media that are available for the rapid diagnosis of MRSA. Now, is it PCR more sensitive? Yes, it has higher sensitivity and specificity, and it allows immediate control and prevention. There are different breakpoints for oxytocin and cephalosporin for staph aureus and cons. That what are the challenges in the testing and typing? There have been resistance to the vancomycin, daptomycin, and the challenge. Identify the interactions between the hospital acquired, livestock acquired, and community acquired is a challenge that is spread to newer reservoirs. Identification of the variants is an issue. So there should be considered decision on harmonization of the typing methods both at a local, regional, and at national level. Patient control interventions include screening the patients, the healthcare professionals, the hand hygiene, contact precautions, cohorting, decolonization, following standard precautions. Optimal stewardship, that is the optimal dosage, duration, frequency of antimicrobial treatment, results in the best clinical outcome of the treatment and control of MRSA infections. To achieve that to go to work with the healthcare practitioners to help each patient receive the most rational antimicrobial to prevent the overuse and misuse of antibiotics and optimize the antibiotic usage. So, screening, isolation, and eradication versus antimicrobial stewardship and infection control needs to be balanced. There are roles of screening, eradication, and isolation. For screening, for that screening the asymptomatic carriers before they get manifested or and spread to other healthcare professionals and the patient. And eradication is decreasing the risk of transmission of those resident organisms. Isolation is the patient who is infected with the resident organism is isolated in order to further prevent and control the spread of drug resistant organisms. However, disadvantage is that there is no international or national standard for the screening, eradication, and isolations. Then there are novel approaches such as antimicrobial stewardship, antiseptic washings, and hand hygienes, which have been proved effective in the significantly in the prevention and control of multi-drug resistant organisms. Then we have clinical. Then there is an article that will report from the Lancet about clinical course and risk factors for the mortality of adult inpatient with COVID-19 in China. It was reported that MRSA was a significant cause of mortality and secondary cause of bloodstream infections, especially sepsis, at a median time period of 9 days. The predictors of mortality and the COVID-19 patients was observed that secondary bacterial infection was suggested by high CRP and procalcitonin, and secondary bacterial infection was seen at a late stage of disease. Organisms included Klebsiella and Staphylococcus and E. coli and Klebsiella in majority. About the viral infections were about 15% that lead to the infections in the COVID patients, were by bacterial infection which about 30% and fungal about 12%. Cases were a major cause of secondary morbidity, and which were unexplored and percent lethal in COVID patients. Rapidly living review and meta-analysis of the bacterial co-infection COVID observed that there were 3.5% of co-infection on presentation, which includes the 15.5% secondary infection after presentations. The 2016 IDSA guidelines observed recommended the glycopeptide vancomycin teicoplanin as a drug of choice for MRSA. Since vancomycin ELF level is 1/6 to that of serum and teicoplanin's ELF level is 1/3 to that of serum, teicoplanin may be preferable over vancomycin. Despite the fact that linezolid has demonstrated fair efficacy in treatment of MRSA, in ventilator acid pneumonia it is preferably avoided in Indian setting owing to the importance as a crucial drug for multi-drug resistant tuberculosis management. Anti-MRSA empirical treatment needs to be considered in COVID-19 patients to reduce the risk of super infections. Now, what's about future vancomycin is no more the choice of antibody for MRSA. A novel genomics-driven approach to drug development is being explored. Molecules that target the fatty acid synthesis such as vinazontin, which is an inhibitor of FABI, has recently been described as a selective inhibitor of Staph aureus. Molecules that target the bacterial RNA polymerase and bacterial protein synthesis are potential options for the future. Tea oil, antiseptic coating, endotracheal tube, and hydrogen peroxide-based gas to decontaminate the environment, and many other such innovative technologies methodologies have been suggested for the prevention and control of such drug resistant organisms. A classical approach composed of screening, isolation, and eradication has many limitations. Lack of standardization of the screening method, lack of medical standards and guidelines, risk of medical errors, the failure to eradicate the resistant bacteria are concerns. With the training of ID specialists, can reduce the usage of antimicrobials, improved hygiene compliance can help significantly. Instruments used needs to be disinfected. Daily antiseptic body washes needs to be. Yes, MRSA is rising in India and it needs to be approached with through antimicrobials. Thank you.